Hello, everyone. I'm Helen Surana. I'm one of the editors at BMJ. I work in our events team, and I'm really delighted to welcome you to our first webinar for Future Health for 2025. We've got some excellent speakers lined up for today. The topic for today's webinar is bringing AI to life in the NHS, insights from successful implementation. And I was just saying to the speakers backstage that this is a really great topic to kick off the year. It's right at the heart of what we're trying to do with Future Health across the year and at our event in November. We're trying to really work with people to make sure the future of health is a reality in healthcare, and we make the most potential of everything that's going on. We've got a number of people just joining, so I'll chat for a bit longer. And what I'm going to say is the way we'll in terms of housekeeping, I will be hosting and moderating. We'll have a couple of talks, and then we'll take questions. So please put any questions you've got in the chat box and the Q&A. We're not going to open any general mics, but I will ask questions on your behalf to the speakers after they've done their initial introductory chat. So that's the way it's going to work. If you've got any questions or technical issues, please put them in the chat. I see there's a question about certificates come up already, and we've got Charlotte and Molly on hand to help with that, with anything like that. But if everyone's ready and happy, I think we've got got 99 participants. 100, yes, we'll start. We're at 100. Sarah, are you ready to take the lead and do your presentation first?
Yeah, absolutely. Shall I go first then?
Yes, I think there's a slide introducing you properly that we saw a bit at the beginning. Oh, yeah, there you go, Sarah Blake. So Sarah's a cardiology registrar in an adult congenital heart disease at the Royal Brompton and Harefield hospitals. She's off to a heart failure clinic this afternoon, but we've got her just before. So Sarah, over to you. Thanks so much.
Absolutely. Thank you very much, Helen. I'll just share my slides then. Just let me know when you can see them. Okay, is that sharing?
Yeah, brilliant.
Fantastic. Yeah, so thank you so much for inviting me to speak. I'm going to be talking about deploying AI in the NHS as a registrar and some of the issues and successes that I've had with that. So I started off by, during my registrar training, applying for a fellowship in clinical artificial intelligence. And this is an amazing venture that's been started at Guy's and St Thomas's Trust, run by the AI Centre for Value-Based Healthcare. And I was one of the first cohort of 10 to 11 trainees who joined and essentially got monthly training in AI methodologies and how to implement AI in the NHS. This is our first cohort, the first time we met. The program runs over a year. I think now they're in their fourth cohort. Initially, it was just in London, but now I think it's based all over the country. And each fellow is also allocated their own project. So I was allocated a project in a hospital in East Kent. And the idea is you're trying to improve efficiency and patient care using AI and running your own project within that trust. So I eventually, after my project was finished, wrote a guide about how we can adopt AI in healthcare. So I'm just going to run through that guide, and I wrote a kind of 5-step approach, and I'll use the example of the project I had in East Kent to illustrate that. So the first point is identifying a problem. So I was just allocated to this trust, and I was told that this was in Kent and Canterbury. I was told they were having issues in the emergency department with out of hours, in particular, chest X-rays were being reported, were not being reported, and so clinicians were missing pathology. And this was one of the problems they wanted to be addressed. And we were going to see if we could use AI to solve this problem. So then, after identifying the problem, we wanted to find a solution. And we were thinking about AI, but we were also thinking about other potential solutions. We looked at different softwares and different companies developing softwares and came across this company, Cure.ai, an Indian-based company, and they basically develop algorithms that interpret all kinds of radiological imaging, so ultrasound, CT, and chest X-ray, using deep learning software. And actually, the good thing about them was they were already in a few trusts in the UK, and they were on the shared business services framework. So this was an advantage for us because it meant we wouldn't have to go through so many of the checks and balances required to introduce something that's completely new. The next part of that was ensuring that although they had an algorithm that had been tested on 1 million chest X-rays across the world, but to make sure it was definitely safe for use in our trust, we wanted to test it on a cohort of our own patients, our own chest X-rays, which is the first thing we did to make sure that it was definitely accurate enough for use. So we published this paper just testing the sensitivity and specificity of the software, which is an essential part of integrating it into care safely. So once we'd done that, we were convinced we could use it. And then we needed to plan its implementation into the trust. And for this, we needed a very good team with all the right people and also establishing the aims of the project. So in terms of the team, we made sure that we firstly, and most importantly, involved the clinical teams. And what I found actually was there's a little bit of, well, quite a lot of skepticism around using AI tools. So we had quite a few sessions of education and just getting the emergency department doctors and their radiologists familiar with the idea that using AI would be safe. And the validation study was a really important part of this because we could show them that on their own chest X-rays, this software actually worked and was safe. Other important people were the software developers, who were working closely with the commercial company, also the IT director, information governance director, to make sure that things were safe and integrated smoothly, and procurement as well. And basically, we were aiming to improve immediacy of chest X-ray reporting. We wanted a software that would instantly give an indication of whether there was important pathology on the chest X-ray. We then wanted to try to streamline work lists by categorizing chest X-rays into normal and abnormal, so that abnormalities would be flagged and looked at quicker. Then the idea was we would audit the films that were normal and potentially move to a point where we wouldn't even need to look at them at all after a series of audit and re-audit to make sure that the software was accurate enough that we could actually ignore those normal chest X-rays. Then the next part, which was arguably one of the hardest, was actually putting the software into our IT systems so that it worked in a way that was useful. So this took several months of working with our IT and making sure that it seamlessly moved into the workflow for radiology and the emergency department. But we did this successfully. And the next slide just shows what you would see once the software was working. So this is the image that would be displayed, produced by the AI software, and it would display alongside the original chest X-ray. And as you can see, it rings the pathology and also provides a report as well, a written report. So then the final step is to continually monitor the performance of the software. So we did this by audit and also by having monthly discrepancy meetings, because at the beginning in particular, there was quite a lot of worry that if there was an error from the software, that it wouldn't be picked up and that it would cause patient harm. This happened incredibly infrequently, actually, but when there was disagreement between the radiologist reporting and what the AI was saying, we'd bring that to a discrepancy meeting and have a discussion to see whether this was something that we could do something about, or whether we needed to adjust the software in any way. And then to make sure that the project was sustainable, because I was only there for 1 year as part of my fellowship, we also trained up super users and who were mainly radiographers, who would then be able to troubleshoot issues with the software. And it was deployed across that trust more widely after this, and also in other trusts as well. So just for my final slide, this is the how-to guide that I wrote as a result of this project, and it just goes through these steps in more detail and the points that you need to cover to successfully deploy an AI software in the NHS. So you can scan the QR code to get the full article, or also contact me for any more details. But this is a useful guide to how it worked for us anyway. So thank you.
Brilliant. Thanks so much for that, Sarah, for that great overview. And just to notice, quite a few people have joined since we started. I said at the beginning, the way we run these is we will take questions, but please just written questions only. So if you've got any questions, please do put them in the chat box and the Q&A box, and I'll put them to both our speakers at the end. So now we're going to go straight into our second setup talk to set up that conversation, and delighted to welcome Dr. Anmol Arora, who is academic clinical fellow at UCL and the lead at the CERG, which I did have spelt out somewhere, but I'm sure you'll spell out for us, Anmol, when you start your talk. So over to you. Thanks so much.
Great, thank you very much. And can you see my slides?
Yes.
Perfect. And the CERG is the Clinical Educators Research Group in Cambridge, and there's a particular focus there on trying to bring in clinicians and medical students into some of the AI work that's going on at Adam Brooks in Cambridge. And I just want to say a big thank you for inviting me here. So my primary role is an academic clinical fellow at UCLH in medical oncology, and I also do a bit of work in Cambridge as well. And I'm really fortunate to have worked on a few AI projects over the past few years, including applying machine learning to some national data repositories for NHS England, while it was still around, I guess. And rather than going into technical detail on any one particular project, I really wanted to keep it broad and focus on some of the barriers of implementation that I've seen. And the big one, which we're going to be talking about, is the data quality gap that exists. Because the primary focus of this webinar, I think, is to try and bridge that bench to bedside gap when it comes to AI. There are a huge number of use cases of AI in healthcare, and we do tend to focus as clinicians on some of the patient-centric uses, particularly computer-aided diagnosis. And that could be in the context of fundus photos, skin photos, x-rays, or just clinical data. But I do think it's important to recognize that there are a lot of other use cases of AI that might actually come about quicker than some of those patient-facing ones. So, for example, at the center of government right now, there are projects to try and go through data reports at a national level to try and pick up trends in our incident reporting and see if we can drive quality improvement centrally. And we don't tend to see that kind of work published in journals. We don't really tend to see it submitted to the MHRA, for example. It's not really a software as a medical device. But these kind of works are being done. And in some cases, they're already being used quicker than some of the computer-aided diagnostic tools that we're going to be seeing. But moving back towards the patient-facing stuff, because I think that's probably what people are most interested in. We've come a long way in the last few years. And this is what I believe to be the frontier of clinical AI research right now, is partly in ophthalmology, but this field of oculomics, for example. In ophthalmology, we've seen AI drive the frontier of clinical AI. Frankly, some of the first FDA-approved software as a medical devices were in ophthalmology looking at fundus photos, and that was about 5 or 10 years ago, and we've moved a long way since then. This is a fundus photo, and it's not just any fundus photo. This is the fundus photo that you'll see if you look up a normal fundus photo on Wikipedia. And I can about tell you that this is a normal fundus photo. A human ophthalmologist would be able to tell you a lot more. They'd probably be able to tell you about all the vasculature here. They'd be able to tell you whether or not the patient has glaucoma, retinopathy, papilledema, a bunch of other conditions. They might be able to tell you that it's probably a young person in this fundus photo. But AI can tell us a huge amount more, because it's already been possible for AI algorithms to look at this same type of fundus photo and tell us all sorts of information: the patient's age, sex, blood pressure, diabetes status, predicting risk of cardiovascular events, and even risk of dementia. And that's what I think is a current frontier of some of this AI research, the idea that we can gain insights into systemic disease from a regional piece of data. In the context of this eye photo, if you've ever been to Specsavers, they'll have looked in your eye and taken one of these photos. And so in the future, there's a small chance that we can look back at all those eye photos and pick up people's risk of cardiovascular events and dementia from that database we already have. Now, in ophthalmology, this type of work has been coined under the term oculomics, that idea that we can get an idea of systemic disease from regional data points in the context of eye photos. But we could apply the same logic to ECGs, where it's already been possible to pick up age, sex, diabetes, or COVID status. We could apply the same to EEGs or chest X-rays, where we're getting similar insights into systemic disease just from simple, routinely collected data points. But naturally, this is a long way from coming into reality at the moment. And we've talked a little bit about what algorithms could do, but what I really want to focus on is what's stopping it from being implemented into the real world. And each of these barriers to adoption could be a presentation in of themselves, to be honest. We're going to be focusing a little bit more on the availability and quality of data, because that is what I believe to be the biggest barrier at the moment. But we have other problems as well. Interpretability and accountability are big barriers which we haven't yet made as much progress on as we have on the data quality issue. Algorithmic bias and automation bias as well have been gathering even more traction in the literature as well these days. Algorithmic bias we'll talk about, but even that stems from the availability and quality of data. And just to highlight that it's incredibly important that we're involving all the relevant stakeholders there, as Sarah said in her presentation. And those stakeholders obviously should be clinicians, but also the regulators, the state, and most importantly, the public. And it's really interesting to see that the UK has taken a leading role when it comes to involving patients and the public in developing AI solutions, including on funding panels and project design. As well as coming a long way in terms of practical development of AI systems, we've also come a long way in terms of development of regulatory frameworks. We're not really at the point anymore where we can say that we don't have regulation yet or it's on the horizon. The regulation is here. We have plenty of clinical trials showing real-world use cases of AI, and we've even got some software as a medical device approvals in the UK, including recently the first Class 3 approval for a software as a medical device, which is regulation to the point of a pacemaker type safety. There are also many FDA-approved software as a medical devices, all available online to look at and see. Ophthalmology, as I say, was paving the way, but there are many more now. And of course, the EU is at the leading edge of AI regulation, especially when it comes to issues of data security and sharing, which the EU AI Act tries to address. As I alluded to before, I think the biggest barrier to AI in healthcare is that quality of data. Good artificial intelligence relies or requires good data. Garbage in, garbage out. We are very fortunate with the NHS that we do have a system which is built for data sharing, a national federation of data. It's embedded within the NHS constitution that the NHS pledges to the public that it'll use their routinely collected data for purposes of research and development to drive improvements in quality and care. We already know that one of the Caldecott principles as well highlights that we shouldn't just be safeguarding patient data, but we should be making sure that we are using it for good purposes as well, under Principle 7. And we're already seeing a really good development in terms of national uptake of secure data environments and trusted research environments on the back of the Gold Data Report, which I'd really recommend anybody reading, because it shows how we can build a national data infrastructure to facilitate AI development. Now, this is our kind of conventional machine learning pathway, and anyone who's developed an AI algorithm will broadly be familiar with it. We tend to focus on the training of the AI models as being perhaps our biggest bottleneck. But to be honest, I'd say that everything around that is probably the bigger challenge. We have challenges at the point of data collection, where if our data collection's been biased, if we're missing out minority groups in there, we will have algorithms that exhibit algorithmic bias. We're also going to be seeing a lot more applications for access to health data, not just by researchers, but by industry and commercial companies as well. And we do need to be vigilant about who we're sharing patient data with. I focused before on how we should be opening up access to academics to do research, but at the same time, we need to make sure we're safeguarding patient trust and using people's data safely. We also need to make sure that we've got adequate systems for post-market surveillance in place. There's a real threat that data might shift over time, whereby characteristics of a population change over the course of a few years, and our algorithms trained on old data might not be appropriate for new data. And finally, I just wanted to highlight that there are plenty of places to look for examples of best practice. UK Biobank and CPRD have some phenomenal data sets, and they've already got robust mechanisms in place for governing access to their data. Standing together is a national consensus guideline report that develops standards on how you should be developing AI data sets. using clinical data to try and mitigate that risk of algorithmic bias. And of course, the government's got plenty of reports on its own website that it's commissioned over the past few years to exhibit how we can use healthcare data to improve AI development. And it's also work in terms of privacy enhancing technologies like synthetic data to think about how we can open up access to data while safeguarding patient privacy. And I think that's all I've got. Thank you.
Brilliant. Thank you so much. I appreciate so much how you've managed to make something very complicated straightforward to understand the scope of in 10 minutes, but without dumbing down any of the issues. We've got loads of questions, so I'm just going to start by saying a couple of people have asked for the link to Sarah's fellowship program that she mentioned, and I'm just putting that in the chat now. So that covers off a couple of them. I suspect there'll be some more questions coming in for you, Anmol, as people reflect on what you've said. But please feel free. I think a lot of the questions, I'm going to ask both of you to give us a perspective on. There are some that are very specific, and Sarah, maybe you could talk about this specifically for your program, but there might be a bigger perspective as well. Cost. How do you start? Obviously, if someone's proposing to put anything new into the health service, then there's got to be a cost element to it, and it's got to prove its worth. How are you costing these? Someone's asked for a per scan cost? Was that a thing that you had to calculate? Is that a thing you do calculate ongoing?
Yes, I mean, that's a very interesting question, and I think it's hugely variable, honestly, but particularly because most of the time you are working with commercial companies. It's very rare that you're going to have the scope in the NHS to be able to develop an algorithm in-house and then use that. So I think a lot of this is about cost and building a business case that then proves that you can improve patient care, which is what we did in my case. So it was not priced for us. It was not priced per scan. It was a sort of using the software per year, which was around £10,000, I think. However, one way that we managed to cut the cost was because we were actually doing the validation study first. We were able to publish that data with the commercial company and get a reduced price for sort of half the year or something along those lines. And I think that's a crucial part of negotiating with these commercial companies, because they do have a lot of funding, but they all are also very expensive. But what they don't have often is a lot of data, whereas in the NHS we have a lot of data that we can offer. So I think you have to be clever about having data sharing agreements in place, signing contracts, but then allowing them to train their algorithms on that data, or like we did, externally validate on that data, because that gives them something they really can't get elsewhere. And then you can really negotiate on the price quite substantially, because this company with QXR, the chest x-ray software, they've then gone on to use that software in trusts all over the country, and they wouldn't really have been able to do that as easily if they hadn't got a solid validation study proving that it was accurate in the NHS already. So I think there's negotiation has to be done, and working with these commercial companies obviously can be costly, but there are definitely ways around it that you can cut costs and work with them.
That's great, thank you. Anmol, have you got any general experience on how different types of AI might be priced, or is that just too complicated and very case specific?
Just to say that actually you raise a very interesting point about the exchange between the company wanting data and the hospital wanting good value for money. And when it comes to long-standing and sustained implementation over time, there's a way to work that in terms of providing data for post-market surveillance. But one of the current barriers a lot of the companies face right now is that they don't have access to the data to do their post-market surveillance, which the MHRA demands. The hospitals hold that data. Hospitals don't necessarily have a financial incentive to give over that data to companies. But if we can do an exchange there where we provide good value for money for the hospitals in exchange for access to that post-market surveillance data, that might help.
Great, thank you. That's really interesting. Should we bite off another big question that's often asked around medical training? Obviously, a lot of doctors on the call, not everyone, but one of the reasons it's often cited, and chest X-ray reading is a classic example, is if your AI is doing all the basics, how do people get trained in doing stuff that AI is now doing? Anmol, maybe you with your education background can talk to that a little bit.
Yeah, this is something we spend a lot of time thinking about in the clinical education group. I think there's one thing to highlight there, which is, let's say, for example, you're a radiologist who's learning from reporting chest X-rays. About 90% of the chest X-rays you go through would be fairly straightforward cases, either normal chest X-rays or bog standard pneumonia. It's only a few that would provide genuine learning when you look at them, those edge cases really. And it's those that we really want to make sure that our doctors are looking at when they're in training. And if we can either isolate those examples for doctors training, make sure that they get a second look, or if we can use AI to selectively generate those training examples for doctors, there are ways we can preserve training, even if we're automating some of the reporting cues in that context. And so one of the things we're looking at is, can we selectively generate, using generative algorithms, training material for doctors to learn from using AI? And so I think there are positive use cases, as well as the typically cited examples of AI replacing people's clinical reasoning skills.
Sarah, have you got a view from your experience?
Yeah, absolutely. I mean, this is a point that came up when we were doing our surveys and pre-meetings before we deployed the algorithm. And radiology registrars in particular were concerned that they just wouldn't have the exposure. But actually so what we ended up doing was, for safety and for training, we displayed the two images next to each other so that you could do a kind of check and interpret it yourself, check what the AI says. And that was very acceptable to most of the registrars. But equally, I agree with Anmol in that actually when they started streamlining so that the normal scans were in one pot and the abnormal were in another, actually the registrars were getting an unbelievable mix of pathologies, and the normal scans were sort of, if they wanted to look at them, they could, but the whole point was they were just looking at scans with pathology. So actually, I think it ended up improving their training, and they were quite pleased with it in the end. I suppose there's another argument that it would de-skill them looking at normal chest X-rays, but there's still, the images are still displayed, so they can look at those normal scans. I think it's just with less frequency because they're mainly looking at abnormal scans, which I think is good for the training.
Excellent, thank you. So we've had a few questions around sort of risks and ethics, which I think sort of is along the same lines of risks, and particularly an issue here where we're doing something new. How do you assess the risks? How do you assess the ethics, and how does that fit into subsequent regulation? And yeah, both from a sort of practical example. Sarah, I'll ask you first, because you've got this really clear project that you went through and can talk about what you did and what you might do next time.
I think absolutely this is such a key issue, and there really isn't that much guidance. I know the government's sort of focusing on it more, and people are writing guidance on safety in AI, and it's so essential. I think a few challenges that we came across was, firstly, working with a commercial company. Actually, that data sharing was quite challenging, and in the end we had to just have signed contracts saying they can't share the data or use it in any way that we don't allow. But there is potential that it can be misused, which I think is one of the worrying things that requires more regulation. I think in addition to that, these new softwares just need, in the early stages, continuous monitoring, not necessarily because they are likely to sort of go rogue, but because the trust with them just isn't there at the moment. So I think we have to make sure that we are being very cautious. And with my project, again, we simply had a very strict way of auditing weekly initially all the normal scans to see if there was any discrepancy, and then monthly when it seemed that things were going well. And I think it's just about keeping things very tight and restricted in the initial phases until you can see that things are working. So I think there does need to be a lot of regulation.
Thanks. Anmol.
Yeah, I completely agree. And I think that there are ways you can de-risk at the start as well. So, for example, using sandbox environments where we don't plug things into the real electronic healthcare system or the real uh, hospital environment. Also, in terms of the data we give people access to. So, right now, I'm co-chairing a group on synthetic data in trusted research environments. So, can we just expose academics and innovators to AI generated or fake data to train their algorithms on? And then once they prove it works on some realistic but not real data, then they can get access to the real thing.
So just for those of us who might not necessarily have it completely clear in our head, can you just go into a bit more detail about what a sandbox is, what synthetic data is and isn't, and then maybe a little bit about federated data and what Goldacre talked about in his review and what's happening in the NHS? Because I think all of that is really useful if you could just sort of explain again headline terms, but I think a lot of people would be interested to hear a bit more detail on that.
Yeah, so maybe I'll go in reverse order perhaps. So in Goldacre's report, it's a very long report, but it's definitely worth reading. It gives examples of how we can improve the NHS or the national data infrastructure in general to facilitate successful AI deployment. And his focus in some of his recommendations was around trusted research environments. Can we build secure data environments online where people can access data in a secure fashion? We can govern who gets access to it. They can run their code within their secure data environment, and nothing should leave their secure data environment. It's pretty similar to the subject of a sandbox, where you effectively mimic what a hospital environment would be, but it's not exposed to real patients and it can't influence things in the real world. Synthetic data is a kind of separate thing, where synthetic data is AI generated data, basically. So if you have a hospital, whether it's Royal Brompton or UCLH, and if they've got access to hundreds of thousands of patient records, most companies or most academics would want access to that data to try and develop their algorithm. But at the same time, there's a competing interest because the hospital doesn't really want to share that because of patient privacy, because of risk of data leakage, for example. But if the hospital is able to create fake records or AI generated records that are highly realistic, they mimic all the same patterns, you can do all the same analysis on it, but it's not real, then that data is much safer, theoretically. And we can start opening access to that fake data instead. I shouldn't really use the term fake data, but synthetic data is the main term, right, where that data is realistic, produces good results, but it's private because it's not real people's data. And in theory, that's exempt from GDPR and exempt from your data protection concerns. Although in our working group, we're trying to really isolate whether that is a gray area or whether it is truly safe. It's early days.
It's really, really interesting. Thank you. And a really good basis for things. And I wonder if, just this is my own question, but, is the landscape then for things like clinical trials changing based on the fact that we can now synthesize big data sets?
Definitely. And actually, what I'm working on a project right now looking at synthetic control arms, for example. So one of the concerns with clinical trials, especially in oncology, is when you've got rare diseases or late-stage cancers, it's very difficult to recruit enough patients to a clinical trial. And obviously, if half of them go to a control group, then that even then limits the amount of people who are really getting a treatment. So can we use synthetic data or AI to simulate what would happen to a control group, really? In that way, you can hopefully assign everybody to your treatment arm, or at least more people to your treatment arm, and increase the power and efficiency of your study. And when you speak to patients, generally people don't want to be in the control group. So there's an ethical argument as well that people have raised. But again, it's very, very early days there. Although the FDA have produced some guidance saying that they'd consider it.
Great. Thank you. We've got another question that comes up quite a lot, but I think is important to address. And you mentioned a little bit, was around making sure that what we're doing is taking account of underrepresented groups in the data, maybe, but ensuring that equity of application. And we're talking specifically here about AI, so let's not go into sort of the digital divide per se, but into how for both of you, maybe Sarah, we'll start with you. Was there a consideration of making sure that you weren't building in or reinforcing biases that existed in the the old system.
Yeah, really good point. And actually, I mean, on the point of synthetic data, I'm less familiar with that, but that would always be my worry, is that your algorithm is only ever going to reflect the data that you've put into it. So if you're putting in data that that underrepresents a particular group, then the algorithm is going to be biased against that group. So the key, particularly, well, for our algorithm, certainly, was that it was trained on this massive number of people that were very diverse. And not just that, but also we then tested it on the population where we were actually using it. So I think that way you can ensure that you get the correct representation for your population. So I think it's all about the quality of data and making sure that the data you're using to train the algorithm includes those underrepresented groups, and that way the algorithm should not be biased. There's always a risk, but I think it's all about the quality of data that you're feeding into it. I think maybe Anmol could talk about how we would make sure that's the case with the synthetic data, because I'm not totally sure about that.
Yeah, I mean, whenever you're training any algorithm, you need to make sure that the data you're training on is representative of the data that will be deployed on. This goes for everything. And I just want to be clear here that the only treatment really for algorithmic bias is the equitize data set that you're training with. That's what the standing together recommendations have shown, that there was an international consensus panel to try and develop these guidelines for how you develop data sets to try and mitigate the risk of algorithmic bias. I don't want to get too diverted in synthetic data, but there are people who say that synthetic data is a kind of stopgap you can use, where you can selectively generate data for minority groups, rebalance your data sets when they're imbalanced already. So if for example you don't have enough data for a certain ethnic demographic, you selectively generate synthetic data for that group to try and rebalance it. It's very contentious and questionable area, but it has been hypothesized. But Sarah's right. If you're generating synthetic data, then it will be the same bias as your real data set. It won't improve bias unless you try and make it.
Okay. Sarah, we've got a few specific questions about your study. So I imagine you've been asked them before. So was anyone's chest X-ray not eligible to be processed by AI? Is there for any particular reason, imaging problems or whatever else? And if so, what were the consequences of that?
Yeah, so I mean, essentially we only used chest X-rays, firstly in adults, so which was over 16, we said, and we only used chest X-rays that were PA-AP films, so no lateral or supine films, and that was just how the algorithm. Again, it's about the data that it had been trained on. So those people were excluded, and I mean, at the moment, I think it was only using. So when we first rolled it out, it was only in the emergency department, and then the idea was to then roll it out into chest X-rays requested by GPs. So those films tended to be high quality films. And then, yes, the ones that didn't meet the criteria were excluded. So I think, again, it's about that training data set, though they weren't included in that algorithm's training. So you couldn't realistically include them in the output. So we had to exclude them, which is a limitation for sure. And potentially there might be an algorithm developed that would include all. And it would have to have a much larger, more diverse training set, training data.
Right, thank you. There's a good question. Well, I don't know if it's a good question. You tell me. I think it is a good question, so I'm going to ask it. How do you address the issue of AI explainability, especially when the solution earmarked for use is earmarked for use by clinicians in the NHS? And I think this issue of explainability, as I understand that, is to what extent can you could a human explain exactly what the algorithm was doing, and therefore that gives people a sense of security about AI, because they think, well, it's replicating what a human could do. Can you maybe correct me if I'm wrong about that in terms of what AI explainability means, and then talk about how that can be a barrier and how you would overcome that barrier with clinicians? Anmol, you're first up on this, I think.
Sure. Yeah, explainability would generally be defined as the ability of a person to try and relay how the algorithm reached the conclusion that it did, basically. And when AI first started out, there were people who were very, very concerned that it's a black box, that we don't know how an algorithm reaches the conclusions that it does. I will argue that there have been improvements over recent years. For example, in terms of variable importance, where we can see what an algorithm is paying attention to. We can see which pixels, for example, of an image that an AI algorithm is looking at when it tries to derive a conclusion. That's how when we see, for example, those funder photo examples, we can see that when an algorithm is looking for cardiovascular risk, it's paying particular attention to the vasculature pixels in the photo. Obviously, there still is an element of unexplainability there. There is still an element of a black box, but we have made some progress. And I'd say that the three things that a clinician should be able to do when this is deployed in the real world are understand in broad terms how the algorithm works, what variables is it looking at, be able to interpret the results, including any error metrics that are produced alongside the output, and be able to interrupt it when it can see that it's going wrong. For example, if a patient with a very rare disease comes into clinic and they've been exposed to an algorithm for predicting genetic risk for some type of cancer, perhaps the clinician knows that actually, because this patient's in a very small subgroup, they might not have been represented in the training data for this condition. And so the algorithm might be a little bit distorted for them. And they might be able to understand why the algorithm reached the conclusions that it did, understand the limitations of it, and perhaps interrupt it when it's potentially gone wrong.
Excellent. Thank you very much. There's another question on synthetic data. Monique, I think you've just hit on a business idea, which is, can't a company create synthetic data rather than hospital creating it? Is there an advantage from it coming from a hospital? So that's coming back to synthetic data, I suppose. Anmol, again, that's one for you. And I'm sure people are doing that. Are they?
There are several synthetic data companies globally. I spoke to most of them to see what they're doing, and all of them have struggled in healthcare. I think pretty much every synthetic data company out there started off saying we want to revolutionize healthcare, and then pivoted towards finance or telecoms or banking, because in healthcare there are a lot of barriers in terms of the quality of the data you're starting with, and we also have excellent in-house people who can do it themselves. So, for example, in the NHS, there's phenomenal work being done with synthetic data already at a national level, dating back for years. And I think any company who tried to penetrate the NHS with data generation was very surprised to see how high quality work is already being done in-house by the NHS, MHRA, and Department of Health.
Excellent, thank you. I guess that sort of leads on a bit to one of our other questions, which is was more of a statement about what's this, and recognizing, sorry to everyone out there, that not all of you work within the NHS. So we've had a question from Canada, is like, does the NHS share its data? But also another question asking about where should the balance be between NHS developing digital expertise in managing data management and using external companies. And I think maybe Anmol will start with you, and then Sarah, over to you on that sort of working with external companies, which you already touched on a bit, but we'll get back to you. So Anmol, that sort of where should the expertise sit, and how is the NHS situated internationally?
From my observation, the NHS certainly has a lot more in-house expertise than you see in other countries, for sure. And part of it is because we have these organizations like the NHS AI Lab and NHSX, NHS Digital, although names keep on changing and things. But we do have the people there who are doing very, very good work centrally. At the same time, things naturally may move a little bit faster in the private sector. And when you look at some of the actual real world MHRA approved medical devices that have come through and can be used in clinic, those have generally been coming from companies. In general, when it comes to innovation, you tend to see that a lot of the groundwork is done by academia and by public sector organizations, and then the final touch for end stage implementation is done by companies. In scientific research, that tends to be a lot of your cellular level research is being done in labs in universities, and then companies come through and try and develop therapeutics based on that, for example. So I think we might see a similar kind of pattern emerging here. Interested to see what Sarah said.
Yeah, and Sarah, it would be interesting maybe to know about your cohort from your fellowship. What sort of roles are you all in now, and where is that expertise sitting in different parts of the health service and beyond?
Yeah, absolutely. I mean, I think you really it needs expertise from all of these sectors: academics, NHS, and commercial companies. And in reality, all three work together in tandem, and you can get in-house algorithms developed within the NHS and within academia, and often those professors or doctors will then take them to a commercial company or create their own startup, which is what's happening more and more. So I think the key really is to be working all together all the time, because the ideas come and the jobs come, and really they can be in any of those sectors. So I think obviously in the NHS, we potentially have not had the funding needed to build big companies that develop really large scale projects, but that's changing. I mean, the AI Centre for Value-Based Healthcare, which is what runs our fellowship, has been expanding, and it has incorporated academics and software engineers and clinicians all together under one roof, getting large sums of money from the government to then develop these in-house. So I think that is happening and changing. Then those people go and start their own startups. So I think the key is to have this network of commercial companies, NHS and academics, so that we're all benefiting from the expertise wherever they are. And certainly my experience working with a commercial company was actually that there weren't as many links as I would have thought. And the skepticism from the NHS side against the companies was quite high. And I had to work hard to sort of broker agreements between the commercial companies and the doctors to sort of make sure that they were even on the same page, right to the point of actually not even speaking the same language. This kind of business speak of client and versus patient didn't really sit that well with the NHS doctors. So I think a lot of it is education and reassurance that we can work together safely, and that the commercial companies are developing things that really can revolutionize the NHS and bring it forward. But a lot of it, needs bridges built between the different sectors, so that we can work together and bring it all forward.
Yeah, we've got a follow-up question, which I think asks that question, which is really who can build the bridges, who's responsible for that, and does the private sector have a role in that bridge building?
I mean, from my point of view, I felt like that was my main role as the AI fellow, actually, because some of my other people in my cohort were sort of designing algorithms, learning coding, sort of working closely in research groups with academics. But my role, I was already working with a developed algorithm and trying to convince doctors to use it. And the thing that was so difficult was the degree of skepticism, particularly against a commercial company who was making money from it, is very high. So I think actually the AI fellows are in exactly the right position. And it's amazing that scheme has broadened across the country, and I really urge people to apply for it, because you'll get the skills to really be able to speak to the commercial companies in a way they understand and translate that back to the NHS, and build those bridges so that we can use these products and revolutionize the NHS, really.
Thanks. There's a couple of questions which I think are related, which are sort of quite interesting to sort of finish on. One is a standard question we see a lot in any health tech discussion is, what can a commercial company do to be best placed for procurement in the NHS? And I'm linking it, and a lot of people wouldn't link this, but I do think they are linked, I'm paraphrasing, I'm a GP, I'm really curious and keen to make the most of AI. Where do I start? There's a whole spectrum of people who are sort of interested in different parts. And one of the things we've been talking about a lot on Future Health is finding solutions for real problems and looking for problems first. I just wondered if you guys, and I'm sure you guys have perspectives on where are those ways in to making a difference for patient care. Anmol, do you want to start?
Yeah, I would just say that it really helps to have an overview or an awareness of the governance frameworks that you need to work through, both if you're a trust or a GP practice who's looking to take something on and not sure whether what you're working with is compliant, or if you're an external provider who's perhaps new to the UK or new to the NHS, and you want to get trial going with a GP practice or hospital. And I know even from the projects we've run locally, one big barrier is that people just aren't aware that what they're developing is a software as a medical device. People just aren't aware that what they are doing needs to go through MHRA approval to be used in the real world. People tend to have a pretty good navigation of data governance pathways. Hospitals are very well equipped to deal with requests for access to healthcare data. But if someone's using that healthcare data to develop a chest X-ray interpretation algorithm, that's an MHRA medical device that needs to be approved. That's a several-year process before it can be deployed or sold into the NHS. And you need to make sure that you're working along that pathway to get that approval in the end. And it's difficult because if you're not paying attention to it from the start, from when you first come up with your idea and start developing it, you're not going to have the trials in place. You're not going to have the metrics in place to try and get your MHRA approval when you need it. So I'd really just recommend people looking at what is a software as a medical device, which class do you need to go in as, 1, 2A, 2B, or 3, and which metrics do you need to prove that you're hitting on to get that approval?
Yes, regulation is definitely a massive issue that, as you say, if you don't address at the start, you can really come a cropper later. Sarah, have you got any sage advice?
I think the main thing, if you're kind of trying to start out using and you want to use AI in your practice, is to define the problem. It's sort of going back to those 5 steps of improving anything, implementing a service change of any kind, is like, what is the problem that you're trying to solve? Because it may be that AI can help, but it may actually be that there's something else that solves your problem. So I think define the problem and then look for solutions that have worked for other people. So the Shared Business Services Network shows, it has a whole list of companies who've gone through the right checks and balances, who've already been approved and already working in other trusts. So I think there's no need to go and find a company that's not regulated, that hasn't gone through those checks and balances. There's plenty that you can actually see where they've had success stories, they've changed practice in hospitals and GP practices, and so I'd start with using software that's already proven itself, and see if that can help your practice as well.
I think that's really key, and again, that's something that we really focused on with BMJ Future Health throughout the year. Is there's a lot of information and work and people and expertise working in these areas, and the problem is not really starting with the problem that you're trying to fix, but trying to come in with a exciting solution or a vague idea that AI is fun and interesting and might help. And I guess the other thing I'd say from experience is, if you want to change something, you are never going to do it on your own. You need to collaborate, and collaborate not with your mate who's also a doctor, but with your soon-to-be mate who is a software engineer or regulatory specialist or product designer, and that way you build great things. So let me just see if we've got any other questions that we haven't delved into. I think we've answered we've covered a lot of ground. I guess there's the finally from both of you. So what are the classic final question, I'm afraid, but I'm interested in what are you currently working on that is going to be something big and exciting? What's the next big thing in your specific area that you know about that might not have hit the headlines yet? I'm looking for a scoop. Sarah.
Yeah, absolutely. So I'm actually a adult congenital cardiologist, and one of the things we're now looking at the Royal Brompton is essentially trying to really revolutionize our outpatient practice. And this is because we follow our patients up for their entire lives, and we see them usually once a year, a snapshot in time. But what we worry about is when they're not with us, when they're out in the world, suddenly something happens and they need medical attention. And with congenital, our centres are spaced out, they're not everywhere, you know, it's not, your local hospital is unlikely to have the expertise. So what we're trying to do is initiate AI risk stratification and remote monitoring. So this would enable us to, by using the massive amount of data we have on these patients and linking with other centers for congenital, to create large AI risk stratification so that we can really know which of our patients are at risk and who we need to see more frequently, and then not need to see the others who are lower risk so frequently. So improving patient care, making things more efficient, and also incorporating remote monitoring. So being able to see, you know, ECG on Apple Watch or blood pressures from home, and incorporate all that data so that we're getting a fuller picture of the patient's health. So that's something we're working on, but obviously will take some time. But it's definitely the way I think a lot of outpatients will be going, so that we're more sure of seeing the right patients, the higher risk patients, and not bothering the other patients as much. Only you know, basically trying to make things safer for them.
Brilliant, thank you. Anmol, what's going on in your world?
Yeah, I'm really interested in that intersection between how do we make sure that we're providing access to healthcare data to academics and to industry for research and development, versus how do we make sure we're protecting patient privacy and the trust of the public. And I'm really interested in, for that reason, in privacy enhancing technologies. Synthetic data is the big one. As I said, we've got this working group which we've recently got funding for, to try and canvass views of the public, researchers, clinicians, data owners, to try and develop some consensus standards. And hopefully by the end of the year, we'll have some progress on that. And we've got an event on the 9th of April if anyone wants to join us.
Brilliant, thank you so much. So I'm sure on behalf of everyone here, and there's some comments coming in saying thank you so much to both of you for your inspiring projects and insightful discussion. I've really enjoyed it, and I think other people have as well. I've got an internal plug, which is for BMJ Digital Health and AI. It's our new journal in this area. So the editor-in-chief, Chris Payton, is keen to hear from all of you who have projects that may be coming to be published. And the other thing to say is we do have another webinar this month. Oh, it's coming up quickly. 31st of March, co-designing digital health solutions, shared learnings from clinicians' experience with patients and industry. So this is going to be really important when we start thinking about that product development side of improving digital health. From a housekeeping point of view, this will go up onto our YouTube channel. If you're not part of our YouTube community or our LinkedIn community, then please do just look up BMJ Future Health and join in with those. And we've got a newsletter as well that you can sign up for to keep track of all these webinars and everything else going on. Charlotte's put a poll up. If you're still online, we'd love you to do a quick poll and tell us if you enjoyed it. Thank you, a couple of people. And as well as you for joining in, we are working with commercial partners to support the work here. So DNV, which is a software company, and Curistica, and Learner Plus, which provides reflective learning software for your CPD. So thank you to those guys for making this possible. And I look forward to seeing you next time. Thanks very much. Goodbye.